And again, welcome back to day 3 of our European Alzheimer conference. The theme is dementia in a changing world, and of course, every day and every year you're aiming to make dementia a European priority. Well, we're back again with a lovely program. We just started with music, and we will move on with a segment that contains many speakers and live discussions. And of course, we will be interacting with you. But first of all, I want to interact with my co-host, co-moderator, and from Luxembourg City, there he is, Jean-Georges. Hi.
Good morning, Kim.
Good morning.
Let's speak Luxembourgish instead of English this morning.
Let's try so. How would you say good morning?
It's goedemorgen. It's almost the same as Dutch, right?
Yeah, goedemorgen. Is that good?
Absolutely.
Okay. Goedemorgen.
If you've been in Luxembourg all your life.
Yes, that's my secret. Nobody knows. I've been there all my life. So we have viewers from all over the world, really, not only Europe. But yesterday we talked to people from Australia, Israel, and they're all attending the conference. That might be an advantage.
Canada, Hong Kong, or the US as well. So
everywhere.
Nice turnout from a lot of European, but also a bit more an international audience.
And one of the advantages of doing an online conference is that everybody can be here, just with a click.
Yes.
True. Yes, true.
Although with time zone, that also makes it sometimes a bit more difficult for people.
I know.
To attend a conference where it is probably a lot earlier or later.
True. Yeah, it's true. We're in Amsterdam here. Today it's bright and sunny. Maybe you can see it, but the sun is on the river IJ and it's beautiful. So changing weathers all the time. But maybe I should say good night or yes, good night or good afternoon to other people in different time zones, right?
Absolutely.
Probably. So we've been discussing things at the conference app, and we want to invite you to do so. And we will provide you with polls and questions all day long. We will keep bothering you, but we also love the activity on Twitter, right, Jean? There's been so many tweets. Yeah. Did you still count? How many?
I will let you know, but I'll let some suspense still going, because if you could just have the kind of presentation with the kind of 4 slides that I have prepared.
Yes. Let's see what the kind of reactions are.
Tweets that we received. So definitely a lot of people have asked or responded to our call of taking a photo of themselves with the poster that they're presenting. They would very often do that at a physical conference, but also at a virtual conference. That's also possible.
Yes.
That's in the next slide.
Yeah.
One of the slides that was really quite popular was this one, which I posted, which just showed that there's a lot of things happening in front of the cameras, but there's an awful lot of work going on behind. And I really wanted to thank here my team in the office for doing a fantastic job, but also the whole live online events team.
They're smiling. They're smiling right now. You see, hey, they're happy. You see Helmi there, she's producing, and you see Lucas behind the camera. You see Sibren, he's inviting all the Zoom speakers. And then with the mask next to him is Marcel, and then we have Sander, but you only see his hair, so that's a shame. But we also have Elwin doing sound. Yes, it's a production team, a small production team.
Team effort.
Yeah, and it is so lovely. Yes.
You know, our next slide, just because one of the points that we discussed yesterday, and we gave you an idea about how many Twitter impressions we've had.
Yeah,
if we go to the next slide, really one of the kind of things that was picked up by people was, well, we wanted over 4,000 tweets by today.
Yeah.
And so a number of people picked that up and said that they would be ready for that kind of challenge. And if you go to the next slide, I can give you an update on
we did it!
And 17.7 million impressions.
Wow. That's the tweet activity button.
Social media can, and also how fantastically interactive all the people in this conference have been so far.
That's an accomplishment, and Twitter is fun, of course, but it also raises awareness all around the world when people tweet this much. That is why we invite you to keep doing that. So let's have a number for today. How many tweets do you want people to send into the world, Jean? Altogether.
At 5,500, I would already.
It's conservative. Yeah, 5,500. We can do this together, so people will know about dementia. That would be great. And we also decided to hand out an award later in the day, right?
Absolutely. So we were thinking of really recognizing all the fantastic work that has been done by the people and how they are promoting our conference. So one of the biggest influencers by this evening will be receiving an invitation to our next physical conference in Bucharest, and Alzheimer Europe will support them with paying their registration fee, their travel, and their accommodation as well. So
an all-inclusive.
An incentive, right?
And it is, it is. So, and what are the criteria to become the biggest influencer?
Well, it's actually we have an app that will check off this, and we will be able to show you at the end of the conference.
So quantity, but also
it's not just the quantity of tweets, but it's also how many tweets did people do, and did people react to them?
Yes,
did people retweet
yes,
them?
interactivity.
If you just
quality
100 tweets and nobody is interested in them, that doesn't count.
That's a good way. That's a good way to judge it. So yes, and then that person will be in Bucharest physically, because that's what we're aiming for, right?
Absolutely.
Yes, that's what we hope for. Now we want to know how you are, because you are here again. We really appreciate that, but we really want to find out how you slept last night. Yeah, well, maybe you are still sleeping because you're in another time zone, or you just put your alarm clock out. But let's see. Yeah, people are voting here, so we are at a 7.02, rising. The people that have slept
basically, if you slept really badly, it was a 1. If you slept really well, it was a 10. So
yes.
7, that probably means that people, they were so exhausted after yesterday.
I think so too.
They just slept incredibly well.
Yes, I think a 7 is quite good, for an average. So are people in here? Are people attending already? Can you see if people are joining us? Probably,
yes, we have 150 people already watching this session. So that's
awake enough to answer our questions. So maybe we can ask the second question to find out how they feel about this conference and what they thought of the content and everything we discussed so far.
And basically, it's we ask people to describe in a word how they feel about the conference. So
exactly, yes.
To see how people react and... Well, we have some nice feedback so far. It was inspiring, amazing, awesome, brilliant, connected, enlightened.
Bloody awesome. Bloody awesome in one word. Love that. Well. Yeah, great. Superb.
Provoking, yes. So
but
nice, positive feedback so far.
You can also enter something if you think you need to encourage us to do things differently. We are open to criticism, aren't we, Jean?
Absolutely. And
organized.
We want to be as good as we can.
Wow.
But we also listen to good.
Brilliant. Connecting, fantastic, enlightened. We feel good now. Belter. What is that? Belter.
A belter is really an English expression saying, well, if you play a belter, it's something that is very, very positive as well. Yeah.
Right. New word. I learned a new word. I love new words. So this is encouraging, Jean. I think that it can. It's a good moment to proceed with the program. Don't you think?
It definitely sets the tone for the rest of the day, I think.
All right. Our next theme, from research and innovation to clinical and care practice. So how do we implement great research into daily practice? Why the theme, Jean?
I think what we listened to yesterday, we heard about fantastic speakers both on how to improve diagnosis, medical management.
Yeah.
We heard about some of the great initiatives that are happening around dementia-friendly initiatives. But I think in each one of the sessions, we also heard that these are sometimes isolated pockets of excellence.
True.
Or things that may not always be picked up in other countries. So what we are trying to focus on with this session is, well, so much research is being done. How can we get better in making sure that the research actually makes a difference to the living lives of people with dementia, carers, and so on?
Exactly. So that's why we invited 4 speakers. And what we will do is they will have their presentation, and afterwards we'll talk to you, we'll present you a question, or Jean will ask a question, or we will try and involve you there. But Carol BRAYNE is our first guest, and maybe, Jean, you can introduce her and tell us why she's here. Hi, Carol.
Carol, BRAYNE is one of these speakers that almost doesn't need an introduction because she's really incredibly well recognized in the fields of epidemiology and public health.
A legend.
Almost.
Yeah.
She's a professor of public health medicine at Cambridge University, but also she's the principal investigator of CFAS, which is the Cognitive Function and Aging Studies. And what she will be presenting here today is some of the results of that fantastic work that she has led.
It's wonderful.
And we're hoping to hopefully hear some encouraging trends when it comes to the decreasing prevalence of dementia in some European countries. And with that, I hand over to Carol.
Lovely. Hi. Yes, Carol.
Great. Can you hear me all right?
Yes, we can hear you loud and clearly. Did you sleep well, Carol?
Fairly well. I mean, it's an early start, of course, for us because we're a little bit ahead of you. But yes, thank you. And it's a bit cloudy. We've had a lot of rain recently, so it's been a bit gloomy over here. We're looking forward to some blue skies.
Where are you here? Where's here?
In the countryside in Cambridge.
Cambridge, yes. I will send the lovely weather your way, all right?
That would be great.
please go ahead with the encouraging trends. We're curious.
Okay, so thank you so much for inviting me to speak at this conference. And of course, it's a groundbreaking conference. So it's really wonderful to be able to share a short presentation with you. And, it's an honor and a privilege. And also, I'd just like to recognize, because I'm an ambassador for the Alzheimer Society in the UK, the incredible work that the charities have been doing during the pandemic in terms of supporting all people with dementia and their families and carers, and also lobbying for dementia care in this very, very challenging time, as well as supporting research and researchers to the best of their ability, despite plunging revenues. So I just really wanted to reflect that and note that, and Jean-Georges, the role of Alzheimer Europe in supporting the charities in their function. So I'm going to talk about these latest trends, and I wanted to unpack the overarching question, and I'm just simply going to go through basically the components of that question, just simply to walk us through what's been happening and how we go about even answering this question. So what is prevalence? What might trends be? How is prevention defined in public health and medicine? And what levers do we have as society globally to influence prevention, and how might these change prevalence? And how can we know whether societal actions are having an effect? So you'll know that the increase in the population of the world is quite dramatic, and most particularly in Africa and Asia, not so much in Europe, in fact. So in fact, we've got a mature aging of our population, but even within that, we have the phenomenon of the increase in the older old. And many of the audience will be extremely well aware of this, but this is very important from a research perspective, because we really need to understand what dementia is in the older old and oldest old, and how that influences care and policy making and so on. Because it's not necessarily the same as the young old that might have been more the greater proportion of people with dementia when our populations were younger, as it were. And we all know that the prevalence of dementia increases dramatically with age. So that's just by way of a bit of a background. So what is prevalence? And I thought I'd just do a quick refresher, because I know that the audience for this conference is a very broad audience. So there's a bath, people who use epidemiologists use a bath analogy to try and help understand what prevalence is. And basically the prevalence, if you think about a bath with water in it, the prevalence is the level of the water. So the proportion of the people in the population who have dementia. So X out of Y population. So we talk about it in percentage terms, because in the older population, because it's it's relatively common. And the only way that prevalence can change is by the occurrence of new cases, or reducing the number of new cases, or changing the death or recovery rate. And of course, our prevention aims at reducing incidence and potentially one might hope improving recovery, because at present dementia is one of the conditions from which there is effectively no recovery. So it's an absorbing, in epidemiological terms, it's an absorbing state, which makes you have to analyze the data in particular ways. So for dementia, death is, so we have to look at survival. That's really important. So this is the way that we understand the balance of incidence, prevalence, and mortality, how that influences the way that we form policy. So just by way of just background. So what might trends be? Well, we have to examine incidence, we have to examine prevalence, and we have to examine case fatality, or when somebody has dementia, how likely are they to die? And that's how we go about examining these things. So over the last decades, I mean, since 1980s, in fact, I've been doing population studies with teams. These studies require huge teams, multidisciplinary teams. And of course, there are a lot of these around the world, but I'm just going to talk about the cognitive function and aging study that Jean-Georges mentioned. So in the early 1990s, this is a very long time ago now, and lots of people in the audience might not even have been born. We did population-based studies in the UK in various sites, looking at people aged 65 and over. These were truly populations, so they included people in residential settings. And then 20 years later, around 2010, we did a next generation study in the same geographical locations. This is in three locations, including rural, urban, and north and south in England. And we compared the prevalence, the proportion of the people in the population who have dementia, across those two time periods. So these are different generations. So what you can see in the blue is the old estimates, and what you can see in the red were the new estimates. Of course, they are now 10 years out of date, so things might have changed again, but it's very difficult to raise money for this kind of work. What you see here is that the prevalence of dementia at each age in this next generation study has gone down, and it's nearly, it's over 20% reduction in age-specific or age-controlled prevalence of dementia. Now, that doesn't mean that dementia won't go up in populations, because as you saw in the earlier slide, the projections for the increase in the oldest old are going up. And so although the prevalence is reducing across generations, because we have more older people, we will still potentially see a rise, particularly if the improvements that we see here don't persist across time. So this was quite dramatic, and it was published a while ago, and it contributed to a group of studies being put together by Alba Hoffman, who led this combined analysis for Europe and the US, looking at studies that could examine across generations. They have slightly different designs. Ours was actually designed from the outset to look at cross-generational change, with independent sampling across time. The other studies are largely sampling from the same population and creating what's called a dynamic cohort. But what you can see here is one, if these spots, these boxes were on the one, that would mean that dementia incidence, that is the occurrence of new cases in people at risk, would be the same. It's not changing across time at all. What you see is that for all these studies, it's below 1. That means that over time, incidence of dementia is declining. There are clearly different patterns, and this is Europe and US, so it's more than one country, more than one region. So this is a very interesting and important finding. And it's very important to note that these studies also held the diagnostic methods steady, because if you change your diagnosis across time, you might have an increase, which is artificial, but which is not actually a change in the population. It's simply that you've changed the boundaries of what you call dementia. We saw this in diabetes when the WHO changed the glucose measures that one uses to define diabetes, and overnight we had millions and millions and millions of people more with diabetes. So we need to be very careful about how we do comparisons across time. So how is prevention defined in public health and medicine? So this is just very briefly, we have primary prevention, secondary prevention, and tertiary prevention. And largely in the early part of the conference, you've heard about secondary prevention and tertiary prevention. Tertiary prevention is making life better for people with dementia and those around them, and potentially trying to treat the things that are associated with dementia. Secondary prevention is early diagnosis, and effectively, if you have early diagnosis, you are moving into the territory of screening. And that could be very early in life, or it could be more closer to when dementia, clinical dementia occurs. And primary prevention is really, really upstream prevention, where you find the risk factors for dementia and you reduce them. And so modeling has shown that the best bang for your buck is to, using the world's evidence on primary prevention, secondary prevention, and tertiary prevention, is that the best bang for buck is to focus on primary prevention and tertiary prevention. I'll come back to that in a moment. And then there are public health frameworks, because of course we as individuals are not simple biomedical blobs. We are people within a whole context and a whole culture and a global culture as well, or global framework. So we can't set those things aside. They all have an influence on our health. So what levers does society have to influence prevention, and how might these change prevalence? So we have at the socioeconomic, cultural and environmental level, we have commercial, social, institutional, environmental influences that can be changed. So we can change our transport policies, we can change our food policies, we can improve education, we can make sure that those people who are in deprived communities do not suffer from inequalities and try to mitigate them. When we think about health services, they're just a very limited part of the impact on our health, from in all sorts of ways, cardiovascular health and so on. And we can do primary, secondary and tertiary prevention within and from healthcare services and from social services, of course, for tertiary prevention. So this is a very important component, but it's actually a relatively limited component in terms of the change, of the drivers for change in brain aging and dementia. And then, of course, we have the ability to influence individual behavior and household behavior. So these are the kind of levers, this is the kind of way that we think when we think about policies. So how can we know whether societal actions are having an effect? Well, I've already mentioned that primary prevention, we have very robust evidence base on primary prevention for all sorts of non-communicable diseases. And we can see how these change across time. So the explosion of non-communicable diseases in lower middle income countries is very much to do with westernization and translation of the not necessarily good practices that we have developed in the West. And secondary screening is expensive and potentially harmful in the absence of good evidence. So we have not implemented breast screening and other types of screening in the absence of evidence. We have had a very good evidence base to even consider early detection and secondary prevention. So we've seen lots of changes in the population across time. I've mentioned coronary vascular disease, so coronary heart disease here in mortality in Finland has declined dramatically. This is just an illustration for women. Observed mortality is the blue line at the bottom, and it's partly explained by changes in risk factors across time. And these trends have continued across time, and mortality for coronary heart disease and stroke has slumped, really gone down very dramatically in Western countries, both because of primary prevention and also better treatment and some early detection, of course. So things like hypertension being defined as risk factors and then being adequately treated. But it's a lot about primary prevention, changes in patterns of behavior in society. So putting this all together, because this is a very short presentation, the Lancet Commission has synthesized the evidence base across the world to look at what might be amenable risk factors that we have identified for dementia and what proportion of dementia this might reduce, so it's called an attributable risk. So how might we impact the future occurrence of dementia by tackling these risk factors? And as you can see, individually, they might seem relatively small, but collectively, they add up to around 40%. And they include things like air quality and hearing and education. So they include things across the life course. So this figure is meant to represent the life course. And many of these factors are associated with inequalities. And so the biggest single thing we can do as lobbying, as public health people, as individuals within society is to argue for reduction of inequalities in society. And that will lead in future to next generations having better brain health and better aging. And so this is a very, very important message from my perspective. It's not enough to treat hypertension. We need to look at the life course of blood pressure rises, which are associated with inequalities, as are obesity and diabetes and physical activity and so on. So these are all really important factors. And I just show this to kind of put it into the broader context that this is the UK. We have not got rid of inequalities in Western countries, and it is a scandal effectively. And this is the difference between healthy life expectancy and life expectancy in the UK, according to deprivation. You can see it's really quite stark. And of course, across Europe and across the world, this is played out even more. So my summary reflections are dementia is changing across generations within populations, and we don't really have enough contemporary evidence. As I said, our data are now 10 years old, and we need new cohorts to examine really what's happening with dementia. It's likely to be changing with increased proportions of people in the oldest age groups. Risk factors are, of course, changing, and COVID has done things in both directions. There's been more exercise in some groups and better eating, and there's been worse in others. So we may see a pulling apart and an increase in inequalities, and the economic impacts may have play themselves out in brain health in the future. So we really need to look at that. Routine records can't measure changes in dementia prevalence because of the changes in diagnostic fashions across time. So we have to have robust surveillance approaches, which are research embedded. The evidence on prevention is very clear. The risk factors, a lot of them, we have a very, very good evidence base. We know what to do. Primary prevention is really good at those things. And we need that to be combined with effective management of existing risk conditions in individuals. It'll be great to have more trial evidence, and that's ongoing in Europe. There is no current evidence that screening and early detection will be effective at reducing dementia in the population at present. The only screening trial that has been conducted so far did not show a positive effect. It's also very expensive. We have excellent evidence that societal changes since World War II in some populations have changed dementia in populations. We don't know exactly what they are, but they have been at societal level, and they haven't been not to do with medication or interventions for particular types of dementia. This has happened in society without us doing anything about it, as it were. Inequalities, as I mentioned, are really, really key to healthy brain aging and therefore to risk for dementia in future populations. And as I said, those who have lobbying powers need to reinforce these messages, even if they don't fit business paradigms. These are changes that also align with the UN Sustainable Development Goals. Mm-hmm. I'm going to put up next. And if we were able to achieve these things across the globe, we'd have not only healthy life courses and healthy brains, mm-hmm. and aging brains. We wouldn't get rid of dementia, but we would reduce our risk of dementia at given ages, and we would also have much greater likelihood of human species surviving into the future. So the views I've expressed are my own, but I acknowledge all my collaborators and the amazing people who've contributed to the cognitive function and aging studies and our funders. Thank you.
Thank you. Thank you so much, Carol BRAYNE. Yes, I was. This was a good start of the morning. You addressing the lobbying power, and also with very interesting figures like the 40% modifiable risk, and the other ones unknown. There's so much to find out yet. But of course, you probably at home or in the office have questions for Carol, and she will be answering questions after our 4 presenters. The Q&A app is open, like you found it. Thank you for finding it and giving us all. Excuse me, Carol, just a minute. Lovely compliments, telling the production team that they did great work, that they love the musicians, that they love Jean and me, thank you, and that they say to the musicians, lovely, don't lose heart. Things will pass, that's what they say. But before you enter your question, Jean might have a question for Carol. This was lovely, wasn't it?
Absolutely. I think it's a really fascinating presentation, and also the kind of positive message that some of the kind of changes that have been happening over the past years actually has led to a kind of decrease in the numbers of people with dementia.
Exactly.
I think the focus was very much on the kind of societal changes that we can do. But I would just wonder, Carol, would you have kind of recommendations for an individual on how they could improve their risk? Because we're not all taking kind of societal approach to prevention. How should we as individuals react to the kind of research that we see?
Well, for an individual, clearly, the messages from the large-scale epidemiological work is really to look after your heart health, look after your vascular health. So keep fit, have a good range of diets, plenty of fruit and veg.
Move, physical activity,
physical activity, social engagement, intellectual engagement. Basically, keep yourself as alive as you can. And I think the thing that I do like to add to it, though, is the sense that you need to be doing it to have about some future health. But actually, it's really important that you do things that you enjoy. So live life to the full and do the things that you enjoy. Try to keep to a minimum the things that you know are harmful for your health. So if you're a smoker, try to give up. If you drink alcohol, keep it within moderation. So, and if you like rich food, there's nothing wrong with enjoying food, but just make sure that the very rich stuff is not as frequent maybe as it might have been when. So it's about a lot of it's about balance in many ways.
Yes.
Ancient wisdom.
True. It's all coming back and live life to the fullest, you say. So that keeps your brain in good shape. Thank you so much for that. Later on, I'm very curious to learn more about the unknown risk part, because this, of course, like you say, is ancient knowledge, but there's more to be found. We will talk to you after the 3 presenters after you. Thank you, Carol, so far. So now, Jean, we will be listening to Alexander KURZ. And he will be talking about improving dementia care by taking advantage of technology, which is quite a thing and a useful thing, I think. Welcome, Alexander. You are a psychiatrist and psychotherapist, senior scientist at the Department of Psychiatry at the Technical University of Munich. There he is. Good morning. Good morning, Munich.
Good morning, everyone. Can you hear me?
Yes, we can hear you. Okay. Yes. Can you hear us as well?
I can. Thank you very much.
Welcome. Yeah. We ask everyone how the weather is at their place of work.
The weather here is quite nice. We have about 10 degrees centigrade. Sun is out. A bit cloudy skies, but for that season of the year, it's quite nice. You were asking before whether people slept well.
Yeah.
To give you a little story from this night, I did not sleep very well.
You did not?
Because I had a dream, and the dream was I had to give a presentation, and the plan was to use a pre-recorded, it's no lie, to use a pre-recorded presentation.
Yes.
And for technical reasons, the pre-recording didn't work, so I had to switch to live. To presenting live, and then I forgot what I wanted to say, so I lost my text, so there was nothing to say. It was a complete disaster. So that was my dream, and part of it became true, and I hope that the second part does not become true.
I'm sure. I know it's a gift because live is, of course, way better than pre-recorded. We all notice the difference. You've already managed to surprise us and make us all laugh. So that's one thing. It's better than pre-recorded. And of course, you'll probably find the words. Before you tell us what you wanted to tell us, if you remember, who's the extra in the background? The lady in the background.
Oh, this is
Hi.
This is Leah.
Hi, Leah.
The project manager of the Indeed project, which we are
I see.
proud to talk about.
Yeah, good, great. So you see, it's all better live already. Please go ahead, Alexander KURZ.
Thank you. So we would like to thank Alzheimer Europe for giving us the opportunity to talk a little bit about the Indeed project, which is an educational program for professionals in dementia care using a little bit of technology. To start with, in the Danube region, defined by this complex of, by this array of countries, dementia already is a major health and social care challenge, or it will be in a few years, because populations are aging in this part of Europe as well. So they are back a few years, but they will catch up in terms of population of people getting older. So, but many of these countries are not well prepared to meet the challenge of dementia. And a few years ago, a group of dementia experts across Europe came together and tried to identify major gaps in dementia care in the Danube region. Now, this picture that photo was taken 4 years ago, but some of the colleagues on the picture may be on the conference this morning. So this group of experts found out that there are 3 major gaps of dementia care in the Danube region. Number 1 is a lack of knowledge and skills about dementia care among health and social professionals. Number 2 is poor interprofessional collaboration and coordination of forces. And number 3 is the absence of important dementia-specific services that are important for people with dementia and their carers. So that was the background for an application at the European Interreg Danube Transnational Program, and we got funded. That was the Indeed program, and as a response to the 3 gaps in dementia care which we have identified, the Indeed program has 3 aims. Number 1, to educate by providing knowledge and skills about dementia, which complements occupation-specific training. Number 2, to connect professionals by enhancing interprofessional collaboration and coordination, and by promoting the use of available services and facilities. Number 3 is to innovate, which is to stimulate entrepreneurial engagement and to support the creation of novel services. The Indeed intervention is available or is delivered in 2 formats. One format is traditional workshops where people sit together, and the other is an online information and education platform. So basically what we are talking about is a form of blended learning, and the online platform and blended learning is particularly important in times of Corona, where face-to-face meetings are either difficult to organize or are impossible. Indeed, overall advocates a person-centered and collaborative approach to dementia care, which is not in place in Southeastern Europe, Southeastern European countries. And person-centered care means to look at activity and participation, to look at autonomy and independence, social relatedness, in addition to controlling symptoms and providing information to patients. So it's not only about reducing symptoms, but it's about the intervention is about improving quality of life of people with dementia and their carers. So we hope that the program will provide a number of benefits for people in the region, in this region of Europe, in terms of an improved quality of life of people with dementia and their family carers, in terms of greater job satisfaction among the health and social care workforce, and as a consequence, maybe to reduce a little bit at least the care and brain drain, which is a problem, a particular problem in these countries. Now, at this point, we can have, and I invite you to have a closer look at the online platform of the Indeed project. As you can see, it has 3 components or modules. One module is Campus. Campus provides information and skills about dementia. So it's about to learn about dementia. The second module is Connect. This is how to engage people in a multi-professional network. And the third one is called Coach, or we call it Coach, which is about creating services, giving advice how to create businesses in the field of dementia. And now we have a closer look, some examples, some highlights of the online platform. One is the navigation is very simple. As you can see, there is a navigation menu which remains visible all the time. So you always know where you are, what lies behind, what you have already worked through, and what lies ahead, what you can look at in addition. So for example, in the chapter Understanding Dementia, there's an outline. Then we talk about the difference between normal aging and dementia, which is not clear to many people. We talk about the causes of dementia, about the different phases and stages of dementia, which means that dementia doesn't always look the same. It's not looking like Alzheimer's disease all the time in all instances. And then importantly, we have a chapter, a section on personal impact of dementia. This is something that people rarely look at and rarely talk about. What does it mean to be diagnosed with dementia to the person and to the people around them? And then we took care to create a consistent design. In terms of graphics, in terms of colors. And as you can see, the color scheme of the Indeed online platform it looks friendly in a way. It's not dark. It's not like a funeral we are talking about. So there are bright colors, and this is the same throughout the online platform. Then we have Powtoons, case studies, where little figures are moving around to tell stories about people who have dementia, a story about a lady who has difficulty preparing a meal, or a gentleman who has difficulty doing his daily exercises and things like that. So again, looking quite attractive and friendly. Then we have infographics, again, nice things to look at and informative at the same time. Here's another example showing some information that Carol BRAYNE has talked about before, namely the modifiable risk factors for dementia. So it's we are not only using words, but we are using symbols to strengthen the information. This is something that you will probably keep in mind when you have looked at it once. Then we are using cartoons. This is a little story starting with the information that dementia does not start in the doctor's office, but starts when someone notices that things are going wrong, like the old gentleman running his car into the house, into the wall of the house. And then that it sometimes can be very difficult to get the person to be diagnosed because they don't want to go to the doctor, and finally they are at the doctor, etc., etc. So little stories that are nice to look at and people will remember. Then we have interviews and quizzes where people are asked questions that again reinforce their learning effects. We have the online platform presently in several languages. This is an example of an interior design for dementia in English, and here it is in Bulgarian. You can see the difference of the writing, and here it is in Romanian. Same thing, different languages. We have it in several more languages. It's available in 5 languages at this time. Now, regarding the efficacy and uptake of the online platform, we have done a little bit of evaluation already. There was a workshop, a face-to-face workshop in Ljubljana. However, due to the corona pandemic, there were fewer participants than we expected, but the feedback we received was very positive. 1 was the lowest rating, 5 is the highest rating, the best rating. So questions were: is it appealing? Is it engaging? Are the topics appropriate, etc., etc. And we, at the right column, you see that the ratings always were close to 5. So the feedback was very good from those participants. And we also had feedback from students in a virtual summer school we had in the southeast of Europe 2 weeks ago. Again, 5 is the best rating, 1 is the worst rating. So the students' ratings were also very, very positive. So the scope of topics was appropriate, the depth of information was appropriate, the level of language was appropriate, and overall, they were very happy when they looked at, very happy using the online platform. So the feedback we received was very positive. And to summarize it, what is special about the Indeed online platform from my perspective? First is the Indeed online platform talks about people and not only about symptoms. So, for example, when we talk about diagnosis, we don't have only the deficits and the catalog of symptoms, but we also talk about the needs of people. With regard to treatment, we don't speak only about some points on a scale, on fancy scales that don't mean anything to anybody, but we talk about the impact on quality of life of treatment interventions with a focus on non-pharmacological treatments. Then the platform talks about dementia in a language that people understand, even if they are not physicians, because we are addressing multiple professions at the same time. And the platform uses a design that is pleasant and varied and convenient to look at. Now that's it. Thank you for your attention.
Well, thank you so much, Alexander KURZ. This was not a nightmare, was it?
No.
No, it was clear. Not at all. It was clear. It was good. We want to. We already started asking the audience a question in the shape of a poll. Jean, why did you want to ask everybody watching and participating about the barriers that they face in Southeastern Europe?
I just thought it was really interesting that Alexander highlighted a number of issues that he said that were very typical for kind of southeastern Europe and the kind of Danube region. My understanding is that a lot of the kind of issues that he pointed out are probably also very similar in other
areas. Yeah.
So just to see what the poll actually says.
Yes. So it asks, in your countries, do you face similar barriers as those identified by the Indeed project in Southeastern Europe? And if you please vote, if you didn't do that yet, do it now, please. Lack of dementia-related knowledge among health and social care professionals. Yes, big part.
The results already.
Yeah, some results.
Give you a quick idea. So
cooperation again.
That cooperation is something that is not happening. That the dementia-related knowledge, 67% felt that was an issue in their countries as well.
Yes.
And then the shortage of dementia-related facilities is something that maybe is not quite as widespread
but
in
still
other European countries as it would be in Southeastern Europe.
Maybe.
Alexander, how surprised or reassured are you by these kind of answers?
Yeah.
No, I think the figures that I'm just seeing, they are very encouraging. So we are not very far off the target.
Okay.
So the first 2 items, the lack of knowledge and skills, this is the general problem. So we can all work together, meaning for me that what we were preparing for the southeast of Europe may also be valuable for other countries, and some aspects of that program may be used by them. And the second thing, that the professions don't work together, that's a problem everywhere. So
yeah, true. Yes,
we need to find ways how people can integrate their forces for the benefit of people with dementia. Because dementia is a very complex disease, so no single professional can really provide an optimal treatment for a person with dementia. You cannot do that alone.
True.
You need partners, and you need to know what your partners are able to do, and what their contribution is. So we are on the right way.
Cooperation, sharing, working together. That's very clear. So please send in your questions for Alexander KURZ, because he will be back, and then there's opportunity for him to answer your questions. Thank you for now so much, Professor KURZ. Okay. So our next presenter, Jean, Dympna.
So we have, as a next presenter, we have Dympna Casey. She is an established professor, and she's the head of the School for Nursing and Midwifery in Galway, Ireland. And she also has a very interesting career, because she combines both the kind of practical experience of being a registered general nurse, but also a professor who has taught a lot of postgraduate
that's
students.
special.
And she's also has a lot of experience in developing and co-designing assistive technologies with end users, so with people with dementia. And today she will be talking about the role of social robotics in dementia. Looking forward to that.
Social robotics. Yes, lovely.
Hi, my name is Dympna Casey, and I'm the Professor of Nursing at the School of Nursing and Midwifery and the National University of Ireland, Galway. And here you can see where my cursor I'm showing you is where we're located in Galway. It's on the Wild Atlantic Way, and the next stop really out here to the west is America. The focus of my presentation today is on assistive technologies and looking at social assistive robots, looking at some of the evidence in relation to same, and also looking toward the future and what lies ahead. Assistive technologies can be defined as any piece of technology used to enhance or optimize functional capabilities. Typically refers to products or gadgets that people use to make their life easier. Robotics emerged in the 1950s. It is an interdisciplinary field of engineering and science, focusing on the design, the development, and the use of robots, including computer systems needed for their control and output and processing of sensory information. Interestingly, the word robot is 100 years old this year. And it was coined by a Czech writer who wrote a play in the 1920s where the robots looked like humans and they did the work of humans, and then they subsequently wiped out the human race. A social robot is an artificial intelligence system intended to interact with humans or other robots. Social robots may be physically embodied with facial features, a voice and expressions, or they may have interactive screens with no human-like features whatsoever. They can be classified into two groups. There's service robots, which are tasked with aiding activities of daily living, and their social or companion robots, which are more generally associated with improving the psychological status and overall well-being of users. Currently, physical or surgical assistive robots dominate the healthcare sector in relation to service robotics. You have sophisticated wheelchairs transforming the limitations imposed on paraplegics. You have robotic limbs redefining amputees' capabilities with the help of exoskeleton suits. And you also have robotic surgeons revolutionizing how and where surgery can be conducted, with most hospitals nowadays having the Da Vinci surgical system for undertaking surgeries, which allows surgeries to be undertaken with more precision and on a quicker basis. You also have humanoid robotics, which are service robots. For example, Pepper being used in the context of hospitals to show patients around and escort them to their rooms. You have Tug, which is transports linen, sterile materials, foods, and prescriptions around the hospital. And you have Robert, which actually can lift and move patients. In the context of dementia, one of the key challenges is loneliness and social isolation. Social isolation is considered to be a modifiable risk in dementia. And the risk to health due to socialization and it has been equated with the risk associated with cigarette smoking, hypertension, and obesity. In the context of long-term care, studies have found that residents spend most of their time socially unconnected and not engaged in any meaningful activities. And Koch 2010 has used the term social death arising from the lack of these meaningful activities. And the consistent and persistent lack of stimulation and social interaction and the boredom and the loneliness actually for people with dementia can actually hasten the progression of dementia. Social robots are increasingly therefore seen as having the potential to provide meaningful activities that and therefore improve the quality of life of people with dementia. Companion robots are social robots in the context of dementia that have been used quite often are the zoomorphic robots, such as Paro is one of the most popular social robots to be used in the context of dementia. It's the baby harp seal. You've got Abio, which is a dog robot created by Sony, and this dog will bark, he will recognize its owner, he will actually roll over and cuddle when you rub him. You've got Now, which is a humanoid robot, and he's about 58 centimeters tall, and he sings and he dances and entertains. And you have the telepresence robot Giraffe, which actually communicates via Skype. You also have an example of Mario, which is a social assistive robot. And this involved from a H2020 EU-funded project focused on addressing loneliness and isolation for people with dementia. It was developed and tested in the real world in 3 sites, in the UK, in the community, in Ireland in nursing homes, and in Italy in the acute hospital. It had a user-led design. It developed 6 bespoke applications tailored to the needs of people with dementia, which are my memories, my news, my music, my games, my calendar, and my chat. And the most popular apps were my memories and my music. To summarize, the impact of Mario was that it increased cognitive engagement, autonomy, and reduced loneliness and isolation for people with dementia. It provided diversion and embodied presence that provided companionship, connectivity, and improved the overall mood of people with dementia. However, carers across all settings felt that the positive impact of Mario was short-lived, and they described it being in the moment only, suggesting that more time and consistent use of Mario was needed to assess the long-term significance of this type of an intervention. Yet the benefits of small positive moments experienced throughout the day for people with dementia cannot be underestimated, and is believed that these benefits of happiness and positive self-perception and overall quality of life make a difference to people with dementia. If we look at the literature, there are 2 more key systematic reviews which are noteworthy in relation to the evidence of the benefits of social robots for people with dementia. Kang et al. Performed a systematic review to describe interventions for Paro and also looked at the outcome measurements following the use of Paro for older adults with dementia. 8 randomized controlled trials were included, and most of them were conducted in a long-term care setting. This review found that Paro can improve quality of life, increase positive emotions and social interaction, and reduce neuropsychiatric symptoms. And the 3 domain of outcome measures to examine effectiveness of Paro identified were quality of life, biological and physiological conditions, and medical treatments. Pu et al. 2019 also carried out a systematic review to examine the benefits of social robots for older adults. 11 RCTs were included, and 80% of participants had dementia or cognitive impairment, and most interventions included Paro. They found that social robots appear to positively impact older adults through reducing agitation and anxiety and improving quality of life. But these positive effects were not statistically significant. And similar to the work of Kang et al., they also highlight a lack of existing high-quality studies. Looking toward the future, we notice that in terms of aging, in 2019, there was more than 1/5 of the European 27 population were aged over 65 and plus. And by 2050, more people over the age of 60 years globally would be in existence than under 15 years of age. By 100, those aged 80 years and over are to double to reach 14.6% of the whole population. Simultaneously, social and healthcare providers are reducing. Currently in Europe, there are 3.5 workers for every person aged 65 and above, and that's set to fall to 2.4 by 2030. For example, in Japan, caregiver shortfall is now emerging, and it's going towards crisis point by the middle of the 2020s. These changes place new pressures on all aspects of life, but in particular care of older people. We also look towards the changes and challenges that are being brought to us in the context of the global COVID-19 pandemic. The death of people with dementia linked to COVID-19 in care homes ranges from 29 to 5% across UK, Spain, Ireland, Italy, Australia, USA, India, Kenya, and Brazil. In the UK and England and Wales, 25% of all COVID-related deaths in care homes involve people with dementia, 31% in Scotland, and 19% in Italy. It's not surprising, therefore, there's been a call to action from robotic communities with a specific call for increased adoption of social robots as quarantine is resulting in prolonged isolation for individuals from social interactions. Social robots could be deployed, therefore, to provide continual social activities, connecting family and friends, promoting adherence to treatment regimes without fear of spreading the disease. If we look at some recent activity in relation to robots helping to tackle coronavirus, which was outlined in The Guardian, in Singapore, parkours had been reminded of their social distancing obligations by the Boston Dynamic Yellow Dog. In Milton Keynes in the UK, the recently expanded fleet of 6-wheeled robots have been delivering food and small supermarket shopping consignments to hungry residents. In China, the Danish UV disinfecting robots have been deployed to actually, with their powerful UV lights, to actually kill the virus. And in Rwanda, the UN actually sent robots there to help to screen patients' temperatures and identify the people not wearing masks and monitor abnormalities in how patients sound or how they might look. And in Japan, you actually have graduations at university carried out with the help of the telepresence robots. But there are challenges for social robots. Some we are have faced, but more serious challenges are coming down the line. Security, privacy, and safety concerned increase as companion robots function with more advanced hardware and software. The technical capacity of social robots to communicate in a more human-like way is likely to increase in the future. And therefore will companion robots change how humans interact with other humans? How do we make sure also that the technology is not just for the affluent who benefit, and we do not further widen the gap between rich and poor? We know companion robots can have a positive impact on quality of life of people with dementia who are already becoming socially isolated. And there is a concern by some people that actually robots may replace human activity or nurses caring for people with dementia. Maybe the focus should be on the coexistence and collaborative efforts between humans and robots, not a decision to be made between one or the other. And that should be more of a focus going forward in terms of the studies and the technologies that are being developed. These new changes and technology and developments will also bring ethical issues and challenges. And I just want to highlight to you an EU-funded Sienna project, which actually is developing a set of practical tools, including new operational guidelines for research ethics committees, codes of responsible conduct, and policy recommendations surrounding the use of AI and robotic technologies in the future. And their website is up on the slide to go to. They have a number of reports written on social robotics and ethical issues. which are really interesting and provide good information going forward as to the consequences of developing technology. So just to conclude, this presentation looked at the assistive technologies and in particular looked at social assistive robots, service robots, and social robots. The most popular social robot that has been used to date is that of the Paro robot, and that has been found to make a significant difference to the quality of life of people with dementia. We've also reviewed some of the evidence and recent systematic reviews which show the impact of the social robots on the quality of life of people with dementia, but many of these actually have poor quality studies and more studies are needed. And looking toward the future in terms of what the new technologies are going to bring for us to be prepared and to shape the technology now by looking at how we can work with technologies to ensure that they best meet the needs of users, protecting the end user, and yet still delivering the effectiveness and capabilities that we know that robot technology can. And in particular, the work that's been done by the Sienna project will help us going forward, undoubtedly. Thank you very much for listening.
And thank you, Dympna. We have the opportunity to thank you in a live setting. Hi, how are you?
Hi, Kim. Good morning.
Hi, Dympna. Where are you? We all want to know.
Like I said, I'm on the verge of the Atlantic. I'm in Galway, in Ireland.
In Ireland, that's good. Yeah,
for once, it's not raining this morning. For once.
It's not raining. No, it's not raining with us either. That's a good thing. So Ireland, yes, we have a Eurovision contest feeling here. We're communicating from here with all the European countries. And Ireland usually wins, right?
Of course.
They do. So thank you so much. Because you were talking about robotics and you call them social robotics, it's common that sometimes the thought of using robots causes some fear or some discomfort. So we wanted to ask our viewers how they feel about that. And we asked them to say, on a scale of 1 to 10, how comfortable are you with the use of social robotics in dementia care? Because, of course, so here we have a result, and maybe we can talk to Jean about that. And then, Dympna, I would love to hear you about that. Jean?
Absolutely. So a very interesting finding, as you can see, like 537 is the kind of average. So that is not exactly a ringing endorsement of social robotics. So
not yet, no.
That there's some kind of concerns around people that maybe half of them are comfortable and the other half are really still have a lot of questions. One thing that we cannot see is whether this number, maybe we started at 2 at the beginning of your first speech, and while you were talking, maybe that average
did it change
over time. Unfortunately, that's something that we can't.
No, that's true.
Maybe over to Dympna. Are you surprised by this, or how can we
interpret this
kind of persuasion work to have people accept social robotics a bit more?
It's not a surprising finding.
No.
And I suppose if I go back in terms of even when I started out myself into looking at robotics, I have to say I was very skeptical and very, thinking, well, I'm not sure, are people with dementia really going to be comfortable with this? And I was very surprised when I went to talk to people who were developing them, because the Mario project was one of the projects I led. And they actually said, oh, this is really anything that can improve our quality of life. We really do want it. These were the people who were experiencing and in the throes of having dementia at the time. But one of the, I suppose, barriers in terms of our causes for people saying that they really were uncomfortable with having robotic technology were for people with some people with dementia felt that they didn't want the choice taken away from them.
Sure.
They actually wanted to make that choice when the day came and not have it made for them in advance, and that they would feel that they could be made to feel babyish and infantilized in terms of having a little dog or a doll or whatever. So that was the concern.
Yeah.
The other key problem was that actually carers themselves, nurses and healthcare and social workers, were really concerned about sharing their space with a robot.
Yes.
And they felt that this was something that they were very uncomfortable about. They also felt that it might take their job in the future going forward.
Yeah.
And it's interesting, I suppose, at the moment I'm involved in another EU project. It's called Prospero, where we're looking at how do we educate healthcare professionals of the future to prepare them to work alongside social robots.
Because they will not be replaced, right?
Exactly.
No, you cannot be missed. Yeah.
They won't, and you still need the physical contact.
Sure.
You know, robots can't give you the physical warmth of a human being.
They can't, and they never will, probably.
No,
no.
I don't think so.
So if there are any other concerns or questions or doubts that you want to discuss with Dympna, please enter them in our app, and then after our last presenter, we will be back with all of the presenters, and you can ask them their questions. So for now, thank you, Dympna. We'll see you in a few minutes. Bye-bye. Thanks. We will be moving on to Carlos DÍAZ, right, John? He is the CEO of Synapse Research Management Partners. Good morning. Hi. Hello.
Hi. How are you?
We're fine. And how are you?
Good. You know, here in Madrid, before you ask me.
Yes. You paid attention.
And for once, it's raining here.
Really? Really? It's a change. It's a good change because we have your son, so you can miss it for a day, right?
Exactly.
Yeah.
Exactly.
It's good that you are here. You coordinate the NeuroNet project, right?
Correct. Yes.
It supports 18 EU projects in the field of neurodegeneration, and you are talking to us about the objectives and results of the date of NeuroNet.
Yes, correct.
Okay. Go ahead.
Shall I go?
Yes, please.
Yeah. Okay. So thanks very much. Of course, thank you, Alzheimer Europe, all of the organizers for inviting me. And I will speak about NeuroNet, but I wanted to. The title of the presentation was a little bit from project results to sustainable assets. So I think that the focus of the presentation will be a little bit more trying to trigger reflection in the audience about how science is organized and whether the actual impact of science can be improved in any way. And I think that in NeuroNet, we're trying different approaches that may be useful for the audience. So of course, I don't have to tell you about the challenges we're facing, which are global. As we all know, we have neurodegeneration in general, Alzheimer's in particular, dementia. Of course, the COVID pandemic has been a very obvious example, a very recent example. But we also saw this year the devastating fires in California, for example. We know about global warming, climate change, etc. So we're facing a number of challenges that are, by definition, almost global. They are very complex, and we heard that from previous presenters. No one can solve it alone. Yeah, there's complexity in all of these challenges, huge complexity. They are grand challenges affecting, in a systemic way, the whole of humanity, I would say. And they're all urgent in the sense that it can have a very detrimental effect very soon. So this is nothing new for anyone. But what I hear, especially with the pandemic, more often is we have to follow the science. Yeah. So the solution for this is to actually wait for science to come up with answers to these challenges. And you have a small caption there at the bottom left. I checked a few days ago, and there's almost 10,000 papers on medRxiv, the temporary repository of scientific publications before they're actually published. I checked yesterday, and it was 9,800 already. So if you do the math, that means something like 1.5 papers per hour that are being produced. So science is very active producing new knowledge. Now the question for me, and I guess for many people, is, but actually, do we have the capacity in terms of workforce, in terms of the overall human resources that we need? Do we have the wisdom, the collective intelligence to actually tackle these very complex challenges? Do we have the resources, the funding? Do we have the speed to actually respond in a timely fashion? Do we have the data? Many people are talking about the data and data sharing, etc., and how we need more. We always need more data. And do we have finally the structure to actually be able to respond to these challenges? So for me, the answer to all of these questions will be a resounding yes, but collectively. So I think that, of course, with the hundreds of thousands or millions of infected people due to the pandemic, we must have the data. Now, most of these studies are actually being pre-published, that are being produced by the scientific groups, are focusing on one hospital, one tiny data set. So we're getting contradicting evidence. We still don't know exactly how it is transmitted, to be precise. What's exactly the clinical KURZ? How's the risk changing according to certain factors? Yeah, and I think that we have to realize how science is organized, and this is something that for lay people, for ordinary people, may not be that obvious. But I think that science is still structured around pretty much heroic individualism, and here you have to understand individual not just as the researcher, the PI of a project or a research group, but also individual companies. Subject to fierce competition, I would say. There's always competition for resources, for funding, for the market, etc. So there's a lot of fragmentation, actually, and we've all seen that. There's overlapping efforts as well, and research is a process that takes a long time. So science relies on long time periods to actually be accumulating evidence, accumulating knowledge that then provides the answer to the question. So we're relying on marginal, on tiny bits of progress over and over. So no wonder that we still don't know many things about COVID, right? Because there's not such a long time that has elapsed. I think it's also affected by institutional inertia in some way. I think that many institutions just by definition, almost by design, the main focus is to preserve the institution, so preserve themselves, say. So that derives in control-based policies for many researchers, I would say. The focus is a lot on preventing misuse of funding, preventing that nothing really wrong happens, rather than perhaps creating the conditions for maximum productivity. Everyone knows that there's publication bias, that the negative results are underpublished, for example, although they may be very valuable in certain contexts. But there's also, what is understood as publishable and non-publishable, and that affects, of course, the efforts of the researchers. There's a multitude, I think, of funding agencies. We see acronyms all the time. There's many people pouring in resources, but perhaps there's too many. I don't know. There's companies specialized in actually figuring out the labyrinth of the different funding opportunities for research. Yeah? There's also, and we're seeing it these days as well, changing political priorities that also affect how science is viewed, what science is viewed as a priority, and what science is a little bit neglected. Nothing more obvious than, again, the pandemic, to see how all of the other diseases have been a little bit neglected during these past months, and COVID seems to be the only disease that there has to be research on. And then, of course, this is a more recent thing, the extraordinary impact of media, I think. I see more experts than ever on TV. And of course, that has an influence as well on how research is approached. There's also the impact of social media. Some people call social media the fifth state by now. So obviously, it has an impact as well. So you have the picture there of the, depressed Superman. But I think that the researchers sometimes can feel like that. And sometimes we think about resilience in the sense of, look, let's cope with all of these factors that are affecting research. But we also have to, I think, reflect ourselves and think about whether actually it is resilience or it is, at least to some degree, acquiescence, which would be obviously something that we have to counter. So, I think we can ask ourselves the question about how science is organized, and perhaps we're suffering a little bit from a little bit of a Middle Ages organization of science, in which you have several castles, and every research group, every company is trying to build their own castle. And some castles are nicer, some castles are uglier, some are bigger, some are smaller. But in essence, castles were designed to be defensive, to protect the contents, say. So no wonder we're having issues with data sharing. No wonder we're having issues with collaboration as well. And of course, we all know that the Middle Ages were not the most brilliant period in history, perhaps, generally speaking. So we have to perhaps ask ourselves, can science provide today timely, actionable results that are actually commensurate with the scale of the challenges? But you could ask me, look, we're seeing all of these projects internationally, nationally, regionally even. So obviously, scientists collaborate. Yeah, there's lots of collaboration. And I would say, yes, of course, there's collaboration. But I would say that the productivity of the collaboration varies. If you can imagine a curve where, productivity has a peak, there's one extreme where there's collaboration happening but too few rules. Essentially, this is the chaos extreme of the collaboration curve, if you like, and that would be wholly voluntary collaboration, say, just depending on the kindness of strangers, if you like. At the other extreme, you will have too many rules, and that normally brings bureaucracy. So, a lot of paperwork, lots of rules and regulations that actually choke innovation to some extent. So, of course, at both extremes, or close to both extremes, there's productivity to be had. I would say that here we have the space of voluntary collaboration, and on the right side, we have a space of tightly regulated collaboration. And if we can imagine a threshold, which would be make a difference threshold, so a level of productivity above which you're actually getting results that have an impact on society, direct impact on society. There's productivity to be had in both of these extremes. But as you can see, there's also a sweet spot in the middle. And I would say that we have to strive to actually attack that space, which would be the world-changing space. And occasionally it happens, but probably if we move too much between these two extremes, it is difficult to actually reach that space. And I see many researchers that actually, in a little bit of a schizophrenic behavior, are moving constantly between the pure academic collaboration in the sense of voluntary collaboration. Let's work together on this or that, but without any sort of funding, etc. And they quickly move towards the other extreme, where you get a grant, but of course that the grant brings a number of rules and regulations that you have to respect, lots of paperwork, and worries about admin issues. So I think that maybe a change in paradigm may be needed here, and in the last decade, certainly in the last 5 years, there's been more and more talking about a systems approach to leadership. And I'll explain that in a minute, but you can see that there is more and more spaces for collaboration that are being created, which are a little bit based on communities of stakeholders, researchers, of course, academic researchers, industrial researchers, patients, regulatory authorities, etc., that are just willing to take action on certain things. Two examples there, the European Alzheimer's Disease Consortium, for example, that unites a number of academic centers voluntarily to try to solve some of the most pressing challenges. But also, for example, Odyssey, the Observational Health Data Sciences and Informatics Initiative, that has many contributions from academics and also from industry, but has managed to promote de facto standards in terms of data harmonization just by doing stuff, just by taking action and saying, look, who wants to collaborate? We don't have any specific funding, but we all feel this is needed. Yeah, you have there a couple of screenshots also. Stanford, the World Economic Forum are talking also about systems leadership. So systems leadership is about creating this kind of non-judgmental spaces where we avoid this fierce competition that I was discussing earlier, trying to gather voices from all stakeholders. I heard one of the previous presenters saying very clearly, we need cooperation. There's no way we can solve these problems all alone. So perhaps we have to abandon a little bit the heroic individualism and try to hear each other, just listen to each other carefully. There's a focus on, of course, trust. We cannot be always in science looking over our shoulder. we cannot always be relying on the not invented here syndrome and say, look, I know better, I'll do this from scratch again. I think we have to abandon a little bit those practices. It focuses a lot on deep commitment to actually solve something. Interestingly, it doesn't focus on trying to solve the whole problem at once. It focuses on small bits of progress. So short-term problem solving, let's try to solve this problem first. This is a small thing that we can tackle, and then we'll go to the next one, etc. To try to make progress more quickly. It is all about co-creation, as you can imagine. But interestingly, it's about creating spaces where, what I call no pitch zones. That means that no one should go to these collaborative spaces trying to sell their stuff. There's no space for that, because actually you have to recontextualize your interest, your own individual interest within global interest, and understanding that my interest is the global interest as well. If we don't solve the global problem, what am I doing here? So it's all about harnessing this collective power, and of course mobilizing innovation in these decentralized networks. You have a diagram there, again from one of the recent publications of the World Economic Forum. So what about NearNet? You're explaining me many things now, but what about NearNet? So I think that the NearNet is trying to be a tiny step in that direction. It is a very exceedingly small project by all European standards, above 1 million euro in terms of funding, only 3 years. And we actually took a little bit of a systems leadership approach there, a small consortium of committed partners per se, but with a very big constituency. And the objective, of course, was to actually see whether we could boost the productivity, the results, the impact of the many different IMI projects in the neurodegeneration space. So to give you an idea of the fragmentation that I was discussing earlier, this was our constituency when we started the project. So you can see here, an inner circle, which is NearNet itself as a consortium. You have then an outer circle with all of the projects and initiatives that we're tackling. And on the left side, you see all of the 18 different projects that IMI has been funded over the past few years in neurodegeneration, 18 projects. So these projects represent more than 230 different institutions, different organizations, scattered over 22 countries, more than 2,300 individuals working for these projects, almost 400 million euro in resources mobilized. So that's quite some capacity, right? It's not trivial by any means. What is the problem here again when we're discussing fragmentation? Of course, each of these initiatives, each of these acronyms and these nice logos, they all have their own objectives. Each project has its own targets. They all have their own calendar as well. Some projects start earlier, finish later, etc. They all have their own mindset. People, when they work together, they develop a culture, a mindset of their own. Of course, that's different across projects. They all have their own decision-making mechanisms, and finally, they all have their own funding to level of resourcing.
Carlos, sorry to disturb you here.
You did something wrong.
You didn't do anything wrong. Now you're just fine. It's just the clock. It's ticking, and I want to make sure that you have the chance to present the conclusions that you feel are really important. I also want to stretch that people are for now, because you've been talking about collectiveness and all that is threatening that. What they feel is what their perception of science nowadays is. So please start filling in that poll, and then we can come back with the results to you and your comments. But maybe you want to choose what you still want to say for your final conclusion in your last seconds.
Fantastic. So as you can see, a very varied landscape and very fragmented as well. What we're trying to do in NearNet is to try to involve all of the projects. So actually the projects are in charge, not us. And you can see that the triangle there, I'm not explaining this, but essentially we're involving the projects at different levels, the leaders, the experts in working groups, and also small teams to actually implement things. So again, we're trying to move the center of gravity from the project to an asset view. And I think that that's very important in terms of sustainability. again, we're trying to actually act as a switchboard across the different projects, so not trying to be an overarching initiative, but trying to actually focus on the specific results that the projects get and trying to connect those, and also trying to serve the common gaps that many projects may have. So for that purpose, we've built an asset map. This is just depicting the different results from the projects, not the projects themselves as a whole, but the different results. And in that context, we're discussing specific assets. And I think that this philosophy of focusing on tangible results that we can actually take forward instead of projects as global entities is an important concept. In the end, what we want is, of course, promote this joint perspective, trying to create a common culture, a common calendar, a common leveraging of resources. So this is my final slide.
Yes, that was a lovely conclusion. Go ahead.
This is my final slide. And I think, well, if we really believe that we're in the Middle Ages, there's many authors that have been describing that after a pandemic, especially, sometimes renaissance happens. Yeah. So how can we actually move from one thing to the other? And I think we can perhaps think about an H3 paradigm, like kind of ladder to escalate and change the phase. And I think the 3 H's would be: we need the heads, we need the intelligence of everyone, we need the hands, we need the workforce, and we need the hearts. Because after all, scientists included, we're all people. So
lovely.
Thank you.
Head, hands, and heart, and a lovely image to keep projecting when you work. Apologies for having to interrupt you, because there's a fulfilled program for the rest of the day. But we want to know, Jean, maybe you can come in and tell us about the results of the poll. What do people feel is what is their perception of science and the threats?
So that's a very interesting slide. So if you can show the results, because we really asked people what they thought of science. Yeah. And so 13% of people came up with the idea that we think that science works well. All the others felt that there's some kind of mismatch in lobbying or so. So some people thought it was too influenced by politics. That was 17%. Some people thought that it was too influenced by the media. That was 4%. Some people thought that actually scientists are working far too independently. That's 21%. But the overwhelming majority of people
corporate
science was a bit too close to corporate interests.
Yeah, still.
Carlos, how surprised are you by these results?
I think that actually, there's a perception that perhaps private interests are too influential. Actually, I think that that's not the main problem, to be honest. So I'm not surprised that there's this perception. I think we have to change that, because I think that the other problems are actually equally important.
Really? Okay, good. That's good to know. So the perception has to change about the perception. Thank you so much. Stay with us, please. And can we bring back all our presenters, because we have questions for them. So hi, everyone. Welcome back again. What we're going to do now is for the last minutes of the session, we will try and present you as many questions as we can that came in. And of course, we will make it short, and you will make it short as well, your answer, so we can talk about a lot of them, because they're all quite important. Jean, you go first. Your first question.
So I have a question for Carol.
Yeah.
And it's really a question around the impact of COVID-19 on the prevalence. With a lot of people dying in nursing homes, do you expect any kind of impact on prevalence in the future?
I don't think it's going to be substantial enough to influence the overarching estimates of prevalence, because most dementia is in the community. It's a relatively small proportion in it's more severe and so on. So I think not. But really, this speaks to Carlos's point. 240 million into all of those initiatives. At the base of those are primary studies, like the study that I've tried to lead over the last decades. The funding, we can't get funding for these studies. And so you've got a lot of money going into all these coordinations, but nothing going into primary data collection on the ground, or not very little, much too little.
Shall we allow Carlos to respond? Because he's nodding, he says yes.
It is true. It is true. So I think that there's, again, as I said, priorities, they change all the time.
Yep.
So lobbying is important, I guess.
Yeah. Alexander, there were many remarks about your Indeed intervention, your training program, and people say it would be interesting for Western Europe, but people also say it would be interesting for everyone, not just professionals. Everyone needs something like this. What do you think?
Well, I think part of the materials could be used for an educational program for carers and even for people with dementia. So we thought about this to expand the group, to enlarge the group of users to other populations, including the carers and including the general public. Absolutely right, because we are not talking in a professional, in a technical language, but we're talking in every man's language. So,
yes.
I'm glad for the suggestion. We talked about that.
Parts of it can be used. Thank you. Jean?
Over to Dympna, because there's been a lot of questions to you from the audience. People also thought that apparently humans will become obsolete. So that was some people that drew that conclusion from your presentation. But on a more serious note, there's also people who were asking questions around what are the main difficulties in the kind of deployment of these robotics in homes? And is it staffing, training? Is it cost or affordability?
Yeah.
What would be the main obstacles?
I think there's a number of obstacles. There is actually cost, of course, in terms of the cost of the robotics.
Maybe. Sorry to interrupt you, Dympna, but your sound is off. Can you please unplug your headset for us? Is that possible? Because people cannot hear you, and we want to hear you. Take the time. Yes, you can have the time. Hey, now she's unplugged everything. Okay, let's move on to another question and hope that Dympna will return. All right, now she unplugged everything, but we probably will be able to have her back. Let's see, because that was fascinating. Jean, do you maybe have your next question? Yeah.
So also a question to Carlos, and I think apparently some people were intrigued by watching you because they thought it was a young George Clooney speaking. So
yes,
something that people thought.
Jean, I had the same. I had the same observation, and I was kind of distracted when I looked him in the eye. I have to admit. Yeah. It's a brother. It's a brother. Yeah.
Note, there was one question around of the NeuroNet portfolio. What were some of the kind of most impactful projects according to you, and why?
Well, I think there's no single project that is more impactful. I think they all are touching on different areas. Of course, some are more basic research, and some are very applied research, very close to cohort studies, etc. I think what is important is that each of those has important assets. So we have to actually cherry pick, the specific result that can actually be sustained over time. I think that there's less and less sense in trying to sustain projects as a whole. A project is a construct. You have to then elicit what is really actionable. So say this data set, this tool, this methodology, and then take those forward. I think that's important thing.
Thank you so much. Dympna, you're back.
Can you hear me?
Yes, we can hear you.
Oh,
so please go ahead.
The barriers in relation.
Yes.
The one of the key barriers obviously is cost, obviously in terms of robotics, but also the technology is not as advanced as we think it would be. So there's a lot of barriers in terms of bringing technology like robots into nursing homes or hospitals because the environmental conditions are not suitable for the technology that's there. So, for example, there's challenges when the robot speaks and it's a noisy environment, which hospitals and residential home settings are. And the person with dementia can't hear what the robot is actually saying to them.
I can imagine.
It may sound like we're in the age of, we have this wonderful like R2-D2 and we have Star Trek type robots, but actually the robots we have are pretty basic so far.
Yeah,
there's a long way to go in terms of the development.
Dympna, another concern that I thought was quite serious, somebody said, might it not make inequality even bigger because it might cost something and then people would have excellent care with a tailor-sized robot and other ones wouldn't. So what do you think about that?
As I mentioned that in my presentation, we have to monitor this carefully because actually you could cause a bigger gap between the have and the have-nots in society.
Right. Mm-hmm.
And that's really important. And there's, I suppose, going back to what Carlos was saying as well about, there is a tendency in terms of projects that are funded, and the EU is great for getting projects funded, but then the project is funded and the continuation of that work sometimes doesn't happen, or you have repeating the same type of work, maybe with a different robot or a different idea, but really the way in which the resources are being allocated does, I think, some of the suggestions that Carlos has made are actually quite valuable.
Yeah, I see. Thank you so much. Jean?
Just a final question from my side, because we've been talking about cats and dogs a lot throughout the whole conference.
Yeah, we did.
And there's also some of the social robotics that you are presenting are basically mimicking cats or dogs. And people were just asking a very serious question, well, how useful have been these kind of robots representing dogs and cats compared to actual cats and dogs in homes and so on?
It's interesting. It's the debate. It's not clear cut in the literature. Some studies actually find that yes, there's been great interaction with, particularly with people with more advanced dementia, with the zoomorphic type robots. But in other contexts, it hasn't worked at all. And in terms of, there's an issue to do with familiarity. So if people are a cat, you know, we say people is a cat person or they're a dog person.
Yes.
They may take more to those type of robots than people who actually are not that into animals as pets.
Again, it's individual.
It is very individual, but also I think going back just to say about the cost of technology in relation to the dogs and the cats and the seals, the Power Robot. Yeah, the Power Robot is quite expensive, but actually there's newer type pet therapy robots coming on the market, like the Joy for All cats and dogs, and they're much cheaper for people.
I see that. That's a good thing. Thank you.
Depend on preference.
Yes, thanks a lot. So, but Carol, we have to go back to your numbers just for a while, because many people vote for this question, and they wonder. They're all impressed and a bit surprised as well. What could be the reason for the decrease in prevalence of dementia among the older generation? These numbers really amazed people. They thought it was not increasing. Yeah.
It's well, we've had increase in longevity, and of course that the reason why we've had the increase in life expectancy is because of basic improvement in our health in the countries involved. And if you look at across the whole of the life course post World War II, particularly in Europe, and aren't terrific, but we've had the introduction in that period of antenatal care, far better delivery of babies, so less kind of, as it were, difficulty around birth, early nutrition. We've had vaccination programs, so we aren't kind of having to cope with multiple infections. We've had less inequality for a period. That's now widening and potentially becomes much wider with biomedical advances and technological advances.
That might.
It's life course interventions which across whole societies.
Very clear. Thank you so much. I think that Jean, we should wrap up now. And please, can we do that by asking you to deliver a one-sentence answer to my question? What would your advice be to make sure that all this lovely research and development is implemented better or faster?
I think that people should use conferences like ours to share their experience, because very often at these kind of events you have people that are multipliers that are interested.
But I wanted to ask that to the panel.
Sorry. But, I'm not giving the answers away, but definitely I think that this is a way of making sure that people can spread the message as widely as possible.
But are they still with us? Our guests, our speakers? Jean's always talking. Yeah, you know who he is, right? Can I please start with Alexander KURZ?
Sorry, what was the question?
You were asleep, probably dreaming. That your advice, because we want to make sure that this research and all your work is implemented in a better way. What would your advice be to all of us to do that? You can't hear me, or can you? Yeah.
Yeah, I can hear you, but I don't have an answer right now.
No? What will you be working on now, from now on, today?
Well, we are trying, regarding the Indeed intervention, we are approaching health and social ministries in order to try to find support to keep the program running after the European support and funding has ended. Then we are trying, we are talking to nursing schools for the same reason. And we are currently working on an Erasmus Plus application to transform it into a regular curriculum or a digital course for students.
Thanks.
So to answer your question,
he came up with it.
About the future of Indeed, but looking at our own work and our own initiatives, it's all about talking to people. It's all about networking. It's all about trying to bring ideas and forces together. And therefore, I'm in great support of what Jean-Jean just said. To bring people together, talk to each other, bring ideas together, combine the initiatives in order to make life better for people.
Thanks. Yes.
In their care.
Make life better. That's good. Something to add, Carlos Clooney?
Yes, I would say I think researchers have to realize they have to break the cycle. You know, I mean, you cannot be always, waiting for grants and submitting applications for them to fail sometimes, etc. I think we have to leverage the collective power. There's many things that can be done just by using our collective capacity.
Right.
And I would agree with the previous speakers. I think that is the priority. There's many things we can do. So let's take action.
Let's take action. Thank you. Dympna?
I think one of the key ways of actually our important strategies is that we involve people with dementia.
Yeah.
So we actually, at all stages of the project, but even one of the things that we build into our project is we have a policy forum at the end, or a seminar forum, where we bring in people with dementia who participated in the program and other people as well, to share with them the results and to tell us really what do they think, or how best can we then get the results into policy.
Exactly. Yes.
So I think that's a good strategy.
Yes, it's been emphasized a lot in these days already. Thank you so much. And to conclude, Carol, what would you say?
Well, I agree with the communication and a dialogue, a discourse with the public and with and co-production with communities about the evidence base that there is for primary, secondary and tertiary prevention across the life course, and basically to lobby so that we all as citizens lobby our decision makers, if you like, about having rational and balanced, non-fragmented approaches to tackling the challenges of our age, which include aging, dementia, but also, as Carlos said, sustainability.
Thank you so much. Thank you, all you presenters. We were lucky to have you and honored because this was high quality. I I know that I can speak for everyone here. So thank you so much, and we will see you in a later time and maybe alive somewhere. Goodbye. Thank you.
Bye.
So Jean, I'll stay here with Jean, and the program will move on at 10:45. The first breakout sessions will be there. Then there will be a break at 12, but there will be, during the break, there will be poster presentations and other presentations. And there's a special presentation at 1, medical management of dementia. You can attend that as well. And the second round of breakout sessions will be there at 2 o'clock. And at 15:50, so 10 to 4, we will be back here with all of you, Jean, me, and musicians and everyone to conclude the day. So Jean, anything I forgot?
I think you summed it up really nicely, but also I think it's very important that one of the kind of key conclusions from here is like, how do you make the bridge to policymakers?
Yes.
And the final roundtable that we will have policymakers from the WHO, from the World Health Organization, from the German government, somebody from Malta.
Yeah.
Who will be, and we can be discussing these questions with them.
That's great. So it's a full circle.
Interesting session, right?
Yes, yes, yes. And we will keep an eye on Twitter, which is very active, lovely, and there'll be an award in the end of the day. So keep twittering at the hashtag 30AEC, please. See you later, Jean. Have a good day.
And you too.
Bye.
Bye.
We'll see you later.